can be reached at any time for remote consultation of complicated cases. Please go to an animal hospital or clinic equipped with Vetis solutions for a trusted diagnosis. Once again, early diagnosis and early treatment for feline HCM is important. Do not miss the early prevention and treatment due to its initial asymptomatic nature. It is time for you to care about your cat.
Good evening. Good evening, doctors. Good afternoon, yes. Salam alaikum. Most welcome to join us for today's online ultrasound series courses with our Professor Eric Lindquist. So before we go to today's webinar, we would like to please allow me to take 1 minute to give a brief introduction about minded animal. So before we go to the Mindry animal, Mindry Group is the biggest medical company in China. And we provide the best health care to the field. And we believe that all lives are equal. So we established Minded Animals since 2 years before to dedicate to providing the best healthcare solutions to the veterinarians. As we inherited from the group, we provide the full range of the medical solutions, including medical imaging, which is the ultrasound, X-ray, the whole OR solutions, including patient monitoring, anesthesia, endoscopy, surgical line, and so on. And also in the diagnosis, we provide excellent CBC chemistries, PCR, urine, and there's more and more products will be released in near futures to cover more species. So the reason we set up the new company is we believe only professionals focus can make things great. So take example in we provide most professional veterinary software in the world. This is our high-end hematologies. With the reticular size, we can calculate 7 reticular size, for example. It's a new generation of CBC to give you very accurate result of the CBC. And we have our dry chemistries. And the Vitafy is nowadays the most selling in the veterinary field for its smart ventilation mode. Our vaporizer FDA approved, so lifetime you don't need go to the maintenance and the calibrations, and it supports automatically ventilation. So it's very easy. You just set up the weight of the animal from 0.5 to 150 kg, so the machine will work automatically by itself. And all our operations or software is after many years development and after many samples from the real species, so that we're able to provide very accurate results. And we also provide full range of accessory to cover different sizes of the animals. And we take very big responsibility to continue educations. That's why today we're all here. And not just the online ultrasound courses, at the same time, we provide a good facility with our local partners, such as in Middle East. We have very great partner, German Standard. I believe most of them, you know them. So we have the training center. We invite a great KOL, and to not just providing the online, but also the real hands-on workshop. So you might contact them also if you any inquiry. So back to today's courses. Today is the series ultrasound course. Last time we done the abdominal, and today we go to the cardiac. So cardiac disease actually is very common, especially in cats. So and the early diagnosis and the video we just see, ultrasound is the gold standard. So today the program will be like 15 minutes for the lectures. Then we can have like around 5 minutes break, and another 60 minutes there will be like techniques. So there's around 2 hours for the whole courses. So rather than that, let's go to today's webinar.
Hello, my name is Dr. Eric Lindquist, the founder of Sonopath.com, and today we're going to demonstrate and explain an innovative approach to performing an echocardiogram in practice. After 14 years of intense clinical mobile sonography in New Jersey and elsewhere, I had to develop a rapid and efficient way of performing echocardiograms, just basically out of the need, given that the caseload was so high. And in order to get through a case and obtain all of the adequate views, I had to come up with a workflow that would be repeatable, whether I was scanning a King Charles Spaniel, or a boxer, or a Dobie, or a Pomeranian, or a ferret, or a cat, or anything else. So what I've done is I've come up with this system to where anyone with good intention and effort and focus and drive can perform an echocardiogram. And this is mainly directed towards veterinarians and veterinary technicians and RDMS that want to learn from scratch or improve their skills and obtain the high-end views. Now here, this is a very, very busy opening slide, I realize that. And the reason why I created this is because there is a large mantra around echocardiograms, and people are afraid of them. And what you're seeing here are many different pathologies and representations of pathologies. Some of them simple, such as mitral insufficiency. Some of them a little more complicated, such as a PDA, or pulmonic stenosis, or DCM and 5-chamber long axis, or DCM and short axis, subaortic stenosis and long axis, subaortic stenosis and apical, ventricular septal defect, and a reverse VSD with a bubble study, which will come up in just a second. But here are 3 different presentations that are simple 4-chamber long axis, short axis sweep from heart base down to the left ventricle at the level of the papillary muscles, and a simple heart base view over on the right. And these are 3 examples of the STEP program. But what I wanted to show here is that all of these views and all of these high-end pathologies, whether acquired or congenital, are all readily obtainable by the system. If you know this system in a progressive manner, and you can do it regularly, repeatedly, and efficiently, you can diagnose, or at least have the image set to diagnose all of these pathologies. And these are essentially the main pathologies that are out there in veterinary medicine. Of course, there are a few other ones that aren't here, but these are high-end representations, and they're all obtained through the S-step progression. But the key is to be repeatable and to be able to perform the S-step progression in a fashion that you really don't have to think about. The best sonography is the sonography that you're not thinking about. So take a look at this system, and when you've watched this video a few times, have your patient maybe lightly sedated with a technician holding him or her on their side and perform this progression with me. So welcome to the S-Step Sonopath Diagnostic Efficiency Protocol Echo Progression. So you may notice on sonopath.com there's a poster. This is the echocardiogram progression. We have one for abdomen, the 17-point abdomen as well. And if you take a look, there are essentially 8 squares here, or 8 rectangles. And each of these are positions or steps in the echo progression. And so if you know these 8 boxes and you perform your scan in the same way every time, you will be able to obtain all the views necessary for all the diagnoses I showed on the homepage. The key here is to obtain, first and foremost, the 4-chamber long axis in this first rectangle up on the left. Position, step A and position 1. And there are 4 positions that we're going to run into. And position 1 is about 3/4 intercostal, right parasternal. And that is where we're going to perform our first position. So if you have an ultrasound probe with you, go ahead and hold the probe like I'm holding it here in the picture. Or take a pen and use the clip on the pen as the marker. So the marker is always towards the head of the patient. And you always want to be no more than 7 o'clock or 11 o'clock, or maybe 6 and 12, but for study's sake, let's call it 7 to 11. You always want to be in that position with that marker cranial. And so, and we'll see why here in just a minute. But I hold the probe in this manner. My forefinger is actually pushing up against the chest of the patient. My thumb is used to hold the head of the probe. Now this is a 6S probe, but it's the same concept if you have an 8C or a 3S if you use the Logic series, or the SP2430 if you use a MyLab Alpha, or any of the other cardiac probes that you may be using. It works for all the same probes, works the same for all probes. The middle finger here is used kind of as a guide, but my finger is always on this marker, so I always know where my marker is. So if I want to put the marker down at 7 o'clock, then I'm going to pull that finger a little bit. If I want to put it up at 11 o'clock, then I'm going to push that middle finger a little bit. And so I'm going to be able to rotate from long axis to short axis, long axis to short axis, based on that little middle finger guiding the marker. My ring finger is used to hold the base of the probe, as is my pinky finger. But the key is here, and we use a similar method in the abdomen by using the entire top of the hand, is to displace the lung field and push against the body wall with the top of the thumb and the top of the forefinger. I'm not pushing with the probe. If I push with the probe, I'm going to agitate the patient. What happens when you agitate the patient? The exam becomes frustrating in a hurry. And of course they get excited, they expand their lungs, they close down your echo window, and you become frustrated. So in order to work with the patient, and this is the same in the abdomen as well, is spread out the pressure that you're applying on the top of your finger and the top of your thumb. And what that does is it kind of comforts the patient, but it more importantly from our standpoint is it opens up the echo window by closing down the lungs. So hold the probe here. Stop the video for a second and practice twisting back and forth the probe at this angle and get a feel for holding the probe in this position. If you've been scanning before and you're not used to this, just tear down anything you've ever learned for a moment and hold the probe this way and try to get used to this, and then see how you like it afterwards. Our first and most important position to obtain, and I can't emphasize this enough, is to obtain a clean 4-chamber long axis. And you're going to see why this is so important. It is very, very important to have the septum, ventricular septum, and ventricular free wall nice and horizontal across the screen as much as possible. Now, longer dogs, you're going to get an inevitable tilt, but such as a Dobie or a Whippet or something like that, you're going to get a little bit of a tilt. A little bit of a tilt isn't a problem, but on all other breeds, brachycephalic breeds or Yorkies or what have you, you have to have this left ventricle be nice horizontal across the screen. And how do you get it that way? Well, there are 3 things that you do with the probe in an echocardiogram. You slide, you tilt, and you twist. And if you slide, to obtain the nice long left ventricle, you're going to slide cranially. Okay, if you have a tilted ventricle, you slide the probe cranially a rib space, and this flattens out. If you need to, for some reason, tilt the heart, then you move caudal a rib space. But typically the issue is that people end up having a tilted ventricle, and so to flatten that out, you move it cranially. Then the next thing you can do is tilt or twist the probe. But it's so very important to obtain this left ventricle in what I call the brick, or a nice long horizontal left ventricle. Because if you don't do that, then all of your measurements are going to be off, and then erroneous interpretations occur, and whoever is looking at your report is going to know that you are not making accurate measurements. Same thing here with the left atrium. And the septum is nice and flat unless there's volume overload. And then the right atrium, tricuspid valve, and right ventricle are less important here because you were usually applying some pressure and that closes this down. But this is a 4-chamber right peristernal long axis. You have to be able to perfect this view. Don't start your echocardiogram progression until you have this view as optimized as possible. So this is the position. We want to move cranial rib space for usually about 3-4 intercostal. Some dogs will actually be 2-3 intercostal, and you want this angle to be parallel with the elbow of the patient. But you have to keep this tail cranial. If you bring the tail caudal here, this ventricle becomes vertical, and which we don't want. You have to bring the tail cranial, and you have to slide cranially until you have the brick, or the left ventricle. Left atrium, left ventricle, mitral valve, a little bit collapsed right atrium, tricuspid valve, right ventricle. And this is so key because you have to be able to have a perpendicular angle for your next 3 measurements, your end-mode measurements. The other thing that we don't see here are papillary muscles. And how do you get rid of the papillary muscles? Well, if you have a long left ventricle, if you have papillaries showing up here, which they aren't in this view, then all you do is twist or tilt. So it's slide, twist, or tilt. STT. Any maneuver throughout the echocardiogram is resolved by one of those 3 things, or a combination of 2, sometimes 3. Slide, twist, or tilt. And remember that the probe marker is going to be at the 7 o'clock position, or you're going to twist it to the 11 o'clock position. One of the 2. So you never go beyond 7 and 11. But between you and me, we know we sometimes go to 12 and sometimes go to 6. But just think 7, 11, so you keep within that parameter. All right? And then slide to flatten, twist slightly to get rid of the papillary, and or tilt. Okay? So as we move forward, STT, those resolve all the problems. So this is a very long dog. I think it was a Dalmatian. And we see our 4-chamber long axis. Here's the left atrium, the mitral valve, and the left ventricle. Left ventricular septum, left ventricular free wall. We start to see the papillary come in a little bit here. That's fine. We twist it out, and it's nice and flat. So I've got a nice long brick. I can get all of my first 3 measurements in this position, which is so key. Know your brick. Get that 4-chamber long axis, and this is your happy place. Just realize that this is where you want to be. If you get out of position, always come back here, start your next step from here. Again, this is position 1, step A, 4-chamber long axis. Follow along on the poster if you have it in front of you. And if you want to see all of the video clips and many, many more, I can plug the Normals DVD that I did with Dr. Peter Modler on the echocardiogram and Dr. Lee Yannick on the abdomen. But all of the efficiency clips and the positions and proper measurements from the echocardiogram perspective are on here, as well as all of the abdominal ones that we talk about in the S-step 17-point abdomen. Remember, 4-chamber long axis. This is the brick. I'm going to refer to it as the brick because everybody remembers the brick. It's a much shorter name. Get your brick. That's your happy place. Nice long left ventricle. Okay? If you're rounding by chance here, if your ventricle is rounding, you're going to twist or tilt to lengthen it out. Okay? But if you have a nice brick that is long here, this is where you want to be. If it's rounding, twist or tilt in order to lengthen that out further. Okay, STT, slide cranial, twist or tilt. And again, these are slight twists and slight tilts. Okay, so now we're on the next rectangle here where we go to the M-mode measurements. Okay, so we're in position 1, and we're going to start with the LVM mode. Now we're in the brick, the 4-chamber long axis. LVM mode, we see that we push the M mode cursor on the logic series. It's this button right here, and I'm sure you're familiar with it. And your M mode cursor comes through and creates a perpendicular cross with the septum and the free wall. So you have your hypoechoic or anechoic area be your right ventricular internal diameter, which corresponds to here. Your ventricular septum, which corresponds to here. Your internal diameter here. And you may catch the mitral valve periodically. That's okay. If it just kind of shows up a little bit, that's fine, because it's catching the extension of the mitral valve or the chordae tendineae that run through here. That's fine. You just ignore them. Ventricular free wall corresponds to here, and this is your epicardium, pericardium, and sometimes you'll have just a trace amount of fluid to be the pericardial fluid, and that corresponds to this right here. So this is diastole, and this is systole. And the difference between diastole and systole is what we call the fractional shortening or shortening fraction. And that's an important measurement that we'll see. In cats, it's typically going to be in the upper 40s to early 50s. And in dogs, the smaller the dog, it's going to be in the upper 40s. The larger the dog, it's going to be in the lower 30s typically. And so you don't want negative measurements. You don't want measurements that in a normal dog that are getting fractional shortenings around 20%. Double check your measurements. You don't want your fractional shortenings up in the 60s to 70s. Double check your measurements if that occurs. So it's very important to self-check yourself. And make sure that your numbers make sense with what you're seeing. And the more echocardiograms you perform, the better you'll get it. Essentially double checking to make sure that your measurements fit with what you're seeing subjectively. So here we go again on the left ventricular M mode. And just remember 30 to 50 on fractional shortenings. That's a ballpark, but it's going to be 30 on the larger dogs, 50 or larger animals, towards 50 in the smaller animals, whether it's a cat or a Yorkshire or what have you. Just remember 30 to 50. Those are numbers that are easy to remember. Now, on the left ventricular M mode, we create the cross with the M mode, the septum, internal diameter, and free wall. And you're asking, well, why is he repeating this over and over again? And as you do this, you'll know why, because this is where everybody makes their first mistake. If you do not have this position in this long left ventricle, everything will be off. Everything will be wrong, and you will be frustrated. So obtain this first. Obtain it consistently every time. As far as the measurements go, and it's different on every machine. So you start your M mode left ventricular steady progression, and your first marker is the leading edge of the ventricular septum, the thickness of the ventricular septum to the leading edge of the endocardium, the LVIDD, which is the internal diameter and diastole, and you stop at the endocardium of the free wall and the epicardium of the free wall. That is a diastolic measurement. So IVSD, LVIDD, PWD, or FWD, depending on the nomenclature of the machine you're using. Where you have this little septal kick and free wall kick, that is systole. Okay, where there's a contraction of the left ventricle. Same thing, ventricular septum, leading edge of the endocardium, leading edge of the endocardium within the left ventricle, leading edge of the endocardium in the free wall, and leading edge of the free wall epicardium. Now, what is important is if you start to get papillaries like this, and sometimes they can be quite prominent, especially in cats, do not measure them. It's very important to look at the whole picture of the left ventricle here. Okay, don't look at little lines that are coming and going. What you want to do is you want to measure the hard, consistent lines that are present, contraction to contraction. So if you get fallout over here and you don't know where to measure, see where the point to measure on the prior or the subsequent contraction is. So you can kind of cheat a little bit and say, oh, okay, this is where I should be. Because that is the consistent line going throughout the tracing. Same thing here, consistent hyperechoic line going throughout the tracing, because a lot of times you'll get interference here, and that's where everybody messes up their measurements, is they're measuring papillaries and sometimes chordae tendineae even. And also remember that your septum and your free wall should be about the same thickness. So if you've got a 0.7 septum, you should have a 0.7 free wall. So an IVSD of 0.7, an FWD or PWD of 0.7, or maybe 0.8 and 0.7, or 0.65, 0.75, that's all cool. But if you have a 0.6 septum and a 0.9 free wall, you probably measured the papillary on the free wall, or you underestimated the septum. So they typically should be a 1-to-1 ratio, because they're supposed to be about the same thickness. Now, on rare occasion, you'll get sectorial hypertrophy or segmental hypertrophy, especially in cats with hypertrophic cardiomyopathy. But as a rule, make sure your IVSD and your PWD are roughly the same measurements. And if they aren't, go back and make sure that you followed the lines correctly from contraction to contraction. Your next measurement, we're still in the brick, and this one's a little bit tilted, all right, so culpa mia. But we're perpendicular enough to where the M-mode cursor is coming through the septum, and we're catching the extension of the mitral valve, and that's called the EPSS, or the endpoint to septal separation. Now this parameter is only really important when we're talking about systolic dysfunction and dilated cardiomyopathy, but it is a standard measurement that we have to do correctly each time. Now this is in better placement, because I have a nice long left ventricle. It's not rounding here, so I've twisted away from me enough to lengthen this out. Now try if you have your patient with you right now, try twisting the probe in 4-chamber long axis. Twist it from 7 to 11 and see how this left ventricle starts to round out, and see as you twist away from you, or the marker down towards 7 o'clock, that this ventricle starts to extend out and gets nice and long. So get used to that maneuver, because you will be doing it for the rest of your echocardiogram life. You want to be able to extend this out and make it nice and long, because here comes the cursor straight down, and it has to be perpendicular here. If it's perpendicular at the septum, it's going to be perpendicular to the extension of the mitral valve. And this is how you measure the EPSS, or endpoint to septal separation. It's leading edge to leading edge from the septal endocardium to the extension of the mitral valve. Okay? And there are usually two waves here. The first extension is what you want to measure. You don't want to measure the second one. So the first extension of the mitral valve leaflet. That's the cranial mitral valve leaflet. The third measurement we do in the 4-chamber right parasternal long axis, or the brick position, position 1 still, step A, is the LA max. Now this is the first of 3 different ways that we measure the LA max, or the left atrial size. The LA max is taken from the atrial septum. If this is left atrium and right atrium, left ventricle and right ventricle, mitral valve, we take the internal edge of the atrial septum to the atrial free wall, and it is parallel to the mitral valve annulus. And some people even make a tracing here so they know that this has to be parallel to it. But I'm not angling way out here. I'm not angling over here. It's straight from the internal edge of the septum to the free wall, parallel to the mitral valve. So the fourth thing that we do in position 1 for the parasternal 4-chamber long axis, or the brick, is to perform a Doppler of the mitral valve. Now, Doppler, there are 3 settings on Doppler. One is color flow, or CF here. Power Dopplers we don't use typically in echocardiograms, but we do in the abdomen. And this doesn't give you direction, it just tells you if there's blood flow, and it's much more sensitive than color flow, just to know what power Doppler is. But for echocardiogram purposes, we want color flow first, color, then the PW, and then logic E, F6 is the CW. Now, the difference between the 3 is color, of course, is color flow. Blue is away from the probe, or blue is away from the probe, and red is toward the probe. So it tells you direction. BART, B-A-R-T. Blue away, red is towards. And it tells you the direction of the flow. Now, pulse wave is a spectral Doppler that we use to identify heart murmurs. And we can get velocities usually up to 2 to 2.5 meters per second. So if you think of a normal aortic outflow velocity in a dog is going to be up to about 2 meters per second roughly, and a pulmonic velocity is going to be up to maybe 1.8 or 1.6, but they're typically much lower than that, between 0.6 meters per second and 1.4 or 1.6. So pulse wave is going to be fine for that. But when you have an audible murmur, typically those flows are going to be well over 2 meters per second. And so what you get is called aliasing. So we detect with pulse wave first, and then if we can't quantify the velocity, whether it's a mitral regurg velocity or an aortic outflow velocity that's excessive, or a pulmonic velocity that's excessive, or a tricuspid velocity that's excessive owing to pulmonary hypertension, then we have to quantify it with the CW. Okay, now on the Alpha or the SAOTE, they have a CW button. So you just push the CW. On the Logic E, then they have the F6. And every machine's different. You just have to know where they're at, but these are standard buttons. So back to the brick. We have a nice 4-chamber long axis, and this is a dog with mitral insufficiency. This is the anterior and the posterior leaflets of the mitral valve. We have a left ventricle. It's a little bit thick, and we see a little bit of a papillary here, but we're not measuring M modes here. This is what we want to concentrate on, the mitral valve itself. And so we take our sector and we put the color flow, we push the CF button, and we get this flow going on through the mitral valve. And where we see that maximum turbulence right at the mitral valve closure, which is imperfect in this case because this dog has vegetative endocardiosis and maybe a little bit of a prolapse. But if you look at you look at the direction of the color flow here, the color flow is going to go in this direction towards the posterior wall of the left atrium. It's almost always in this direction. Occasionally I'll go in this direction, but most of the time it's this direction, or I head back this direction. So what you need to do is you have to have your Doppler angle within 20 degrees theta of flow. Okay, in this case the flow is heading in this direction. So we have about a 10-degree offset of the flow. But we put the gate, the sampling gate, right behind the closure of the mitral valve. And we do this, and it's very important. You don't put it out here. You don't put it in front. You put it right behind the closure, and you match it up with what we call the weather channel, or the big storm coming through. Because the Doppler looks like, the storm coming through, the big hurricane coming through with all this turbulence going on will create a mosaic pattern. So we put the gate on the mosaic pattern. And when we do that, we get a nice clean envelope with a maximum velocity. And this is important. I'm going to explain why. Because on the left side of the heart, mitral insufficiency velocities have to be over 5 meters per second in dogs. And if you're not getting a regurgitation velocity of over 5 meters per second, you've underestimated it, and it's usually an angle problem. Okay, you're usually not within 20 degrees theta here, or your cursor is offline with the maximum flow. And so we have to put it right on the turbulence, and when we do that, within the angle of flow of this regurgitation, we get a nice clean envelope. And see this envelope, we want it nice and clean, a big upside down triangle essentially, and we don't have artifact around it. This is what we want to shoot for, and we want to measure the highest velocity we can obtain. The other important thing is, in this particular dog, it's 6.3 meters per second. Well, when you have a mitral insufficiency velocity that's that high, you have to consider systemic hypertension being an issue. And we can go into all the Bernoulli equation and Starling's laws and so on and so forth, but that's beyond the scope of what we're doing right now. But it's important to just have this line up correctly. The other point is, if you don't have the mitral valve closure to the right of the screen, then it's going to be difficult to get this angle within 20 degrees theta. So put your left atrium over to the right, and you can slide caudally a rib space if need be, and every dog's different. We're still in position 1, but you may have to slide caudal to position 2 from the 4-chamber long axis, and we're going to get to that in just a minute. But make sure that left atrium's on the right of the screen, that mitral valve's over to the right a little bit. Put the color flow on first. You can put PW on first, but this is going to be a high velocity regurgitation. So go color flow and then CW in order to quantify. Because if I had PW here, it would stop at 2 meters per second. It would alias, so that's useless to me. I need to quantify this insufficiency jet. Okay, so we've gone through a lot here just on the first step, but realize that 70% of the echocardiogram is performed in this position. Most of your measurements are done here, and the mitral insufficiency is done here. And this is the #1 Doppler flow that you're going to need to get on a regular basis, because there's a lot of mitral disease out there. So, and just double check, make sure you're getting well over 5 meters per second. If you're not, double check your angle. Make sure that your flow, or your waveform is nice and clean, upside down triangle. So, from here, we're going to go to step B. We're still in position 1 now. We're going from 4-chamber long axis to 5-chamber long axis. And the way to achieve this is the same position that we were in before, but it's a slight twist of the probe. So the tail of the probe is cranial, and we're going to see that in just a second. But now we're going to twist the probe slightly, and sometimes it's a slight twist and a slight tilt. Remember STT, slide cranial to make the ventricle long, slight twist to get rid of the papillary, and if you do that also, you twist a little bit more, and you're going to get the aorta coming in. So now we have 5 chambers. We have the left atrium, the mitral valve, the left ventricle, which we had before, but now we open up into the aorta, okay, and then the right atrium and the right ventricle. So now we have 5 chambers here, and this is very important because when we have a 5-chamber, our main scope here is to obtain the LA to AO June-Boone method. And what you want to do is slide the probe caudally a little bit, slide the probe cranially a little bit in order to get the LA to AO position in the middle of the screen, and I'm going to explain why that is important. You want that aortic valve in the middle of the screen, and this is the position. See, the probe's in the same position that we were before, but now we're going to do a little tilt. That's what these arrows are. We're going to tilt the tail up or the tail down just a little bit, or we're going to twist just a little bit. So we're not going to do a huge twist, because we do a huge twist, then we lose our left ventricle and it becomes a short axis view, which we're going to do in the next step. But we do a nice long left ventricle here, and a slight twist and a slight tilt, and we get the aorta and the aortic valve in the middle. We want that aortic valve right in the middle between the 2 walls of the aorta and the left atrium, because here we can drop our M mode cursor to get our LA to AO right in this position. So remember, slight twist, slight tilt from the prior brick position to become 5-chamber long axis. So this is the maneuver going with the slight twist and the slight tilt. This is an efficiency clip off of the Normals DVD. And we're going from 4-chamber to 5-chamber. 4-chamber to 5-chamber. And you see that aortic valve right in the middle there. So in order to obtain this, have the probe in your hand and do a slight tilt and a slight twist. And you will go back and forth. If you have your animal with you, go ahead and perform this procedure, and when you have it down, go on and move to the next step. But you can see that that left ventricle is still long. It's not rounding. It is nice and long, and if this starts to round in and you start to see the tip of the left ventricle, then twist away. Try a slight twist and a slight tilt in every combination. And it may take a while. And if your hand starts to cramp, always take the probe off the patient, and take a deep breath, and then go back at it again. So anytime your hand cramps, just realize you're creating bad habits. It's a reflex. It's what happens. I've taught hundreds of people how to do this, and just realize if you start to get frustrated, you're going to create bad habits that you have to strip down later. So we're going 4-chamber to 5-chamber. So we're brick at 4-chamber and brick at 5-chamber, back and forth. Okay. So when we have that 5-chamber, and this is a cat with a 5-chamber, left atrium, left ventricle, a little bit of papillary here, aortic valve right in the middle. This is one of Peter Modler's images, and we put the cursor, the MO cursor, right down the pipe through that aortic valve and through the left atrium. When we do that, we get this kind of tracing. or a split tracing, depending on what your machine is set at. And you get the aortic valve in the middle. This is the aortic valve closure, and then it opens up, and that's the box. Okay, we're going to refer this to the box, and the box is the aortic valve opening. Okay, and so when we measure our LA to AO and June boom, and notice that the aortic valve and the LA to AO position here and the LA to AO position here are essentially in the middle of the screen. Don't have them over here and don't have them over there, because you're going to be offline. You have to have them in the middle of the screen. And that way the cursor is going to hit that aortic valve and the aorta and the left atrium in perpendicular fashion. And when you do that, you get a clean aortic valve right in the middle between the two walls. And you follow that aortic valve closure to the end, and that is where you measure the aorta, leading edge to leading edge. And then you follow this line up to where it maximizes in the left atrium, and then you measure the left atrium, leading edge to leading edge. Don't measure the left atrium here. It's aorta at the end of the aortic valve closure, prior to the opening or prior to the box, and then the left atrium at the end of the box or the beginning of the next opening, or just measure here to here, follow that line up the hill, and then measure from here to here. So aorta to left atrium, or LA to AO ratio. Now in a cat, that's typically up to 1.4, sometimes 1.5. In a dog, 1.15 is normal, sometimes 1.2, maybe 1.3. But if you're getting values much more than that, double check to make sure you are not overestimating or your measurements. You're not overestimating the left atrium, because if you get an LA to AO in a normal cat that says 1.8, that says on paper that that left atrium is big. But if the left atrium isn't big, then that cat may get medication inappropriately. Okay, so that's where it all comes down to. Again, measure the aorta, leading edge to leading edge at the end of the aortic valve closure. Box opens, follow that line up the hill to the left atrium, leading edge to leading edge. Okay, so next step, we're done with on step B. Now we go to position 2 and step C, the rectangle at the far right, top level. Okay, and realize that we're all downhill from here. I mean, we've done a nice job so far. Most of the bulk of our measurements are performed in the first 3 boxes, the first three steps. So step C, position 2. So now we're going to slide caudally a rib space, and we are going to take a look at the right atrium and pulmonary artery. And we're going to get our Doppler there as well. So instead of having the tail of the probe cranial, like we did before, angling back in position 1, we're going to slide back caudally a rib space, or in small dogs it's essentially just bringing the tail of the probe caudally a little bit. And if you have your probe in hand, go ahead and do this. Same position, you're holding it the same way. And what we're doing here is we're lining up the probe with the right atrium. So if you raise the tail of the probe, you get the right atrium and the tricuspid valve. The tricuspid valve will be right about 2 centimeters. And if you lower the tail of the probe, then we're going to get the pulmonary artery. Okay, I'm in the same position. The hand position's the same, and I'm just lowering the tail. So raising the tail, pointing down towards the table, I get the right atrium. Lowering the tail of the probe and pointing up towards the dog, I get the pulmonary artery. And you'll see that pulmonary artery come right down the pipe. This is the pulmonary artery. Right ventricle, pulmonic valve, pulmonary artery, main pulmonary artery, and the auxiliary, or the split. And this is where the pulmonic valve is, and this is where you're going to put your Doppler cursor to get pulmonic outflow velocities. But let's say you want to get a diagnosis of PDA. Well, your Doppler area right here, this is where the PDAs live. So if you put color flow over this, you're going to get a big mosaic pattern. You put CW spectral Doppler over this, you're going to get a big holosystolic waveform. That's how you diagnose PDA. But realize that in position 2, all of this is pulmonary artery, the tail is down, right atrium, the tail is up. So you're just going up and down with the probe, pointing to the right atrium, and down with the tail, and you're going to get the pulmonic valve. Now the key is here is to push with your forefinger, push against that right lung lobe. The right medial lung lobe gets in the way, it comes over the heart. And so you push on that with your finger, not with the probe, you push on that, and then you just kind of do little micro maneuvers and find your sweet spot. It's very important on echocardiograms to find your sweet spot. Get your best image possible and work from that. Don't move to the next step until you have a pretty window. And one window may be one position on one dog and another window on another dog from another position. So it's important to move that lung lobe out of the way with your forefinger and adjust little micro maneuvers until you have the pulmonary artery coming down the pipe or the right atrium coming down the pipe with the tricuspid valve. And then once you get one or the other, then you just bring the tail up and tail down, tail up and tail down, video clip it. Once you have your pretty view, you video clip it, and if you want to see more of these views, take a look at the CD as well. And this is the right atrium to pulmonary artery view, tail up and tail down. And you should get a video clip like this. Pulmonary artery, right atrium. Pulmonary artery, right atrium. Right atrium, tricuspid. It's going up and down, up and down. So practice that maneuver. Again, this is position 2, step 3. And once you have this, then you can move to the next thing, which is the Doppler. Now the Doppler is the same thing. We can put the color flow over first and then the pulse wave. And if you have an excessive velocity, you can go to CW. And anytime you're measuring Doppler on valves, the perfect way to do it is to put the gate prior to the valve and push the PW button. And here you're going to, and the color flow and then the PW button. You can check pulmonic insufficiency prior to the valve. For outflow velocities, you do it just after the valve, and for PDAs in this particular view, you're going to put it in the main pulmonary artery in this area here. So it's always 3 samples of every valve if you want to be perfect about it. But typically, we're going to look for insufficiency on color flow. If we're not seeing any significant insufficiency, we're just going to get our outflow velocity right here, right at the closure of the valve, get a nice waveform, and move on. And you'll get something like this. Nice pretty pulmonary artery. So we have the tail down at this point. Pulmonary artery, the gate goes right at the valve and you get a nice clean waveform, and it's going to be somewhere between 0.8 meters per second and 1.4 meters per second or something like that. And remember, when your outflow velocities, you want your baseline to be up at the top. So just adjust your baseline to the top. Give yourself space for that waveform to fill in within the space provided. Okay, and you can maximize your PRF, and that'll give you more space to work with. So the PRF is set at 2.7 maximum meters per second. So this is about 1 meter per second on the outflow velocity, which is normal. Okay, so if we raise the tail now and we get to the right atrium, we're going to get the tricuspid valve closure. And what we want to do, just like we did with the mitral valve, we put the gate just behind the closure of the 2 tricuspid valve leaflets. And so you get an E wave and an E wave and an A wave, and between that you get an insufficiency jet very often. And in larger dogs, tricuspid insufficiency is quite physiological in many patients. However, when you have an insufficiency jet, not just some valve noise like this is just valve noise, this is just valve noise, it's artifact, but when you get a solid waveform that comes down and shoots through the other side, that's called aliasing. And see, this is the end of it over here. So I can raise the baseline up here and try to fit this waveform, or I can raise the PRF to the maximum, which would be maybe 250 or 2.5 meters per second on this. But if it's aliasing on that, then I can just go over to CW, from PW to CW, and with CW, just like I did on mitral valve, I am going to quantify my waveform. And in this case, it's 4.46 meters per second. On a tricuspid valve, that is moderate pulmonary hypertension. That is a clinically significant parameter, even moderate to severe pulmonary hypertension. So we have to be able to quantify this tricuspid insufficiency, because pulmonary hypertension is 2.8 meters per second or higher. And so if we're aliasing here, we're not going to know if that's 2.8 meters per second or if it's 2.6 or it's 4.4 unless we put CW over it. So color flow first, PW, with the gate right at the valve closure, and that valve closure, that insufficiency jet usually heads, just like the mitral valve, in the same direction. Mitral insufficiency jet head in this direction. Tricuspid insufficiency jets, most of the time in my experience, go in this direction as well. And again, we have to play that same lineup game that we did before to make sure that we maximize our outflow or our tricuspid insufficiency velocity, like we have right here. Nice clean waveforms, we take the maximum velocity. So the next step, after we get, after position 2, is we go back to position 1 in step D on the bottom. Now we're working across the bottom, we're almost to the end of our scan, and we're going to do some interesting maneuvers, some efficiency clips, and we're going to go 5-chamber long axis to short axis heart base, and from there we're going to slide through the whole heart from heart base down to the apex of the heart in a 3-second maneuver. So this is step D, position 1. We're back to position 1 like we were before. Tail cranial, right? Remember position 2, the tail was caudal. Now position 1, we're back here. Just like we're going to take an LA to AO in the June boom position. LA to AO is right in the middle. The aortic valve is in the middle of the screen. This is very important because what's in the middle of the screen in long axis is going to be in the middle of the screen in short axis. And so we want to have the aorta in long axis go to aorta in short axis. So we're going to twist now. We're in the 7 o'clock position, and we're going to twist to the 11 o'clock position. So 7 to 11. And now 11 is going to be short axis, 7 is long axis. So if you have your probe in the hand, then do that twisting maneuver, 7 to 11, 7 to 11. If you have your patient, go ahead and start to do this maneuver. So what you're going to do is now you're twisting the probe until the marker is at 11 o'clock. It's technically at 12 o'clock, but don't tell anybody. It's easier to remember 7-11 here. But we're at 11 o'clock now, and when we bring that, twist that probe to 11 o'clock, we get the aortic valve, which was in long axis before, becomes short axis now. And we get 3 leaflets. This third leaflet's kind of falling out. But we get the Mercedes-Benz sign. And it's not a heart base if you don't have Mercedes. Okay, so we want to have this aortic valve, or the aortic valve leaflets, all 3 are the best we can get to it, and a nice closed aortic wall. Okay, we don't want ventricle over here. We want this nice closed wall here because that's the position that we take our LA to AO on the heart base. So in this position we have the aorta and the Mercedes-Benz sign, the left atrium, and a superimposition of the left auricle and the pulmonary artery that comes down. So you can get your pulmonic outflow velocities here as well. Right ventricle's here, right atrium's over here. But what we're paying attention to mainly is the aortic valve in this position and the left atrium. So practice going from 7 in long axis to 11 in short axis. Going back and forth, and you get something like this. Position 1, long axis. Position 1, short axis. 7 to 11, practice this efficiency clip. Long axis, twist to short axis. Long axis, twist to short axis. 1, 1000, 2, 1000, 3. And this is a cat. And it's very important if you learn to do these efficiency clips, that you can go back and measure everything after you've saved the clip. You can post-process all of this. So you can do efficiency clip after efficiency clip and then go do your measurements afterwards. So if you have one of those unruly patients or these crashing cardiopathic cases that you really have to find out what's going on, you can learn to do these efficiency clips. And it's one of the reasons I came up with them, is to be able to do an emergency echocardiogram and then post-process everything afterwards. You can't get high-end Doppler in post-processing, but you can do your measurements. So I can do, for example, from this position, LVM mode, EPSS, LA to AO June Boone, and LA to AO heart base. Okay, and if I had more time, I could do pulmonic velocity, mitral, and tricuspid velocities, all in this 3-second video clip. So this is how important it is. Just imagine the clinical applications of an efficiency clip like this, from 5-chamber long axis to short axis heart base. And there are many variations of that, of these efficiency clips on the DVD. So let's say we just saved that video clip and now we want to measure the heart base. Well, So we scroll to the heart base where we have the Mercedes-Benz sign, and you can see the first measurement is from the internal edge of the aorta, and then we measure the left atrium, internal edge to internal edge, and they are lined up in the same position. Internal edge to internal edge, internal edge to internal edge. And a lot of times you get the pulmonary veins coming in that you get fallout here. Just follow this hyperechoic line and create an imaginary line between the two, and that's where you want to stop your measurement. But make sure that you're transecting the aorta, or the Mercedes-Benz. You're transecting that right across the middle through the left atrium in the second measurement. So that's the LA to AO heart base measurement, and typically 1.4, 1.5 or so is going to be normal, and depending on the study that you do. So the next step we're going to do in the efficiency clip is go from heart base to the mitral valve, which is mid left ventricle, or the fish lips view, or further down towards the apex where we're going to get the papillary muscles, or the mushroom view. Now, you can also do your LVM mode from this position. I just find it easier to tell when you are in proper position by having long axis left ventricle as opposed to short axis. I find that people have trouble lining up correctly and deciding when they're oblique or not. They have more difficulty here in this short axis than they do in long axis. Because if you have a nice long brick and no papillary muscles, you know you're lined up correctly. But how do you tell that on the left ventricle in short axis? You have papillaries, but it's so easy to get off line here and be oblique on this view. But ideally, you get both measurements, and so do what you feel comfortable with, just as long as you're consistent from exam to exam. So on this maneuver, we are going to go heart base to fish lips to left ventricle in 3 seconds. I was like, well, how do you do that? Well, you start where you were before, short axis, and now what we're going to do is we're going to move our hand up and down. So we're moving the tail up and down, just like we did on position 2 when we were going right atrium to pulmonary artery. Now we're going to do it from the heart base up and down. It's the same maneuver. It's a tilt up and a tilt down. Some dogs, it'll be slide, and sometimes you jump a rib space like I'm doing on this one. You get a rib popping in there. Mercedes-Benz to fish lips to left ventricle mushroom. 1,000, 2, 1,000, 3. And this one, again, I had to jump a rib space to do it. Some dogs, you have to do that. Others, you slide up and down the ribs. Others, you tilt up and down. But usually it's a tilt of the tail up and a tilt of the tail down. And you get heart base, fish lips, mushroom. Or aorta, mitral valve, papillaries. So imagine you can get your heart base, you can get your LVM mode, you can get your pulmonary artery, you can do a lot of things. Tricuspid insufficiency, you can do a lot of things with this position. But it's a great morphological assessment of what's going on in the heart from short axis, from the base down to the apex. So our next position here is position 3 we're going to go. So we just did position 1, step E, and we're going to step F now in the second box on the bottom. And we're going to look at the right atrium and right auricle. Well, this is essentially looking for right auricular masses, pericardial effusions. And the dog is still, or the cat is still on the right side. We haven't moved the animal. And that's the benefit of this program, is the patient is always comfortable on their right side. They don't have to go anywhere. And it's very important if you have respiratory distress going on, you don't want to excite them any further than you need to. Use Torbutrol if you need to apply a little bit of sedation. You will not have any significant functional issues with the heart with Torbutrol on board. So this is what we're looking for in position 3. All right, this is what we call the beer can view. All right, I always use these little terms because everybody remembers beer can view as opposed to now left parasternal right auricular view. And so what we're looking for here is we're driving the probe right down the right ventricle to the tricuspid valve, and we get the right atrium and the right auricle. And you have to find your sweet spot there, and we can enhance the sweet spot by applying pressure with the back of our hand that we'll see just in a minute. But this is the money position right here. This is where right auricular masses are found. This is where pericardial effusion starts. And so your typical splenic mass in a golden retriever or a German shepherd or a Labrador, and you want to find out, does this dog have pericardial effusion, right auricular masses? Do a number 3 beer can view before you go take that spleen out. Because in our own study, about 15% of dogs, and study about 78 or 80 dogs that it's non-published information, we found a 15% concurrent pericardial effusion of right auricular masses with the concurrent presence of a splenic mass. So it's very important. Imagine the political issues. You go in and take out the spleen, and the dog has pericardial effusion, comes back in clinical in 3 or 4 days. It doesn't go over well, and it's a waste of resources when you have metastatic disease. It can be approached in a different manner. And so it's just a quick issue that we can address very quickly from the right auricle with the patient laying down on its right side. So this is what we call the hammock. So beer in the hammock is what we're going after here. And this is what I mean. Everybody's held a beer can. It could be a soda can if you don't drink. And the probe is going to be like the beer can. But the marker is towards the head still. It's in that 7-11 position. Now I'm using the back of my hand now to spread out along that left cranial, left medial lung lobe and collapse it. So it's going to enhance my window. I'm going to come right off of the sternum, and I'm going to kind of fish around a little bit with pressure only from my hand but not from the probe until I find my sweet spot, where I'm going to get my right ventricle, and then I'm going to see the tricuspid valve. You start with finding a beating heart. If you have a beating heart, that's a start, okay? And once you find the beating heart, you use that window until you find the tricuspid valve come in and that right atrium, and you see the hammock. Just to the right of that hammock at the 4 o'clock position on the screen is where your right auricle is. And you can just angle to maximize that right auricle and the visibility of that region to assess if there's a right auricular mass or not. And this is what it looks like live. Beer can position, pressure with the back of my hand, coming off the sternum. This is left ventricle, little vegetative mitral valve here. Right ventricle image is a little bit dark. Tricuspid valve, right atrium. This is the hammock we're looking for, and we can see the right auricle popping up and opening up. This is normal. This is fat deposition at the base of the heart. This is all normal. No masses, no fuss, no ugliness going on here. You can also do your tricuspid Doppler here if you like. If you had trouble with one of the other views, you can use your tricuspid. Just drop the tricuspid PW Doppler, put the gate right at the closure of the valve, fish around there, look for your tricuspid insufficiency, which we don't have. This is just valve noise. This is absolutely normal. So that's finishing step F. So we move over to the third box on the bottom, step G, which is position 4. Now position 4 is apical. The patient's still on the right side. We have not moved the patient. We won't move the patient unless we absolutely have to, because we can get all of these views from the right side. And so what we're going to do now is we're going to play with the aorta and the aortic outflow. It's our last Doppler view. And depending on which direction you have the marker on the probe, you can have the left atrium on the bottom right, you can have the left atrium on the bottom left. The bottom line is we're looking for the ventricle and the aortic outflow. And we have to get this within 15 degrees theta, as we explained before. So we're going to drop the cursor right down the ventricle to the valve and put the gate right post-valve to get our outflow velocity. If we want to check for aortic insufficiency, we're going to check right there. We'll put color flow over first, see if there's a mosaic going or a red flare coming off of that aortic valve. Because BART, blue is away, red is towards the transducer, okay? So if you have a red flare here, that's an insufficiency jet. You can put the PW Doppler over the top of that, and you can measure it and quantify it. You can also get your mitral valve Doppler here as well. Tricuspid Doppler you can, it's a little bit lumpy to be able to do that, but both of these Doppler readings of the mitral valve and the aortic outflow velocities and aortic insufficiencies you can get from this apical position. And it's very quick, very easy. These last 2 steps are very quick. Once you know how to do them, you go from position 3 to position 4 and you're done. So it's a matter of just being able to do the maneuver. Everybody that I've taught, once they've got this is the easiest part of the echo. And whereas traditionally these were difficult views to get. So regarding the position, okay, it's important, it's imperative that you use your top of your fingers here to push against the abdomen and push against the a little pressure towards the diaphragm of the dog. And that does a couple of things. One, they'll put up with it, because if you push with the probe, they're not going to like it. Use the top of your hand to push against the belly, flatten out the belly, especially in overweight dogs. You'll flatten out the belly, and it'll create a little notch for the probe to go in right under the xiphoid. And you're not pushing with the probe. But what that also does is it renders all the tissue more compact and creates a better window for you. So it kind of squeezes the liver right up against the diaphragm, and the diaphragm has light pressure on it, and you'll find the heart a lot easier. So what'll happen is, if you have the heart in this position, great, this is where you want to be. But if the heart's over to the right, you need to flatten out the probe more. Okay, that means your probe is angled too much, more like you'd be going after a gallbladder as opposed to going after the heart. You have to flatten that probe out. If the heart is over here, it'll come over here. Okay, so try that. And once you have that down, then go ahead and continue with the rest of this presentation. Try moving the probe, the tail up a little bit, and see where the heart goes. It's going to go over to the right. And as you drop the tail and push it more lined up right on the linea alba, it's like you want to lay the probe on the linea alba with your hand pushing the viscera towards the dorsal vault of the patient. And that will allow that that heart to come down into the middle of the screen. Now, if you're not seeing the aorta, it's very easy. Anything that you need to lengthen out anywhere in the body is a twist of the probe. So all you do is just twist the probe until you get that aorta to open up for you. Now, the aorta is going to be typically down at 5 to 6 to 8, sometimes 12 centimeters in depth is where you want to go. So you have to have the right probe to do this. Now, the 6S probe will do that okay for a 20 kilogram dog, or 20, 30 pound dog, but after that you kind of need the 3S probe. And I'm sure there are appropriate comparable probe issues with the other machines as well. So this is what it looks like. Left ventricle, mitral valve, left atrium over here, or it could be on the other side. Either way, depends on which direction you have your probe marker. And the aorta is right down the pipe, and this is the aortic valve. So you're going to drop that cursor, that PW, or you can put the color flow over, drop the PW and the gate right at the aortic valve, and you're going to get an outflow velocity. And it's about 7, 8 centimeters of depth. Same thing here. I'm moving the heart around a little bit. I'm looking for this long aorta. I could get some Doppler over my mitral valve if I wanted to. Nice long aorta here is where you want to go. Again, probe against the belly. If it's not against the belly, the heart's going to go over here. You want it in the middle, have the probe flat on the linea alba. So this is where you put the gate, right after the aortic valve, down the pipe here. You have the left ventricle, in this case the left atrium over here, and the mitral valve, and the gate right after the aortic valve. And you get a nice clean envelope. And it's going to be typically over 100, typically 150, 180 centimeters per second. In boxers, they tend to run high, around 2 to 2.4 meters per second, or 200 to 240 centimeters per second. If you have A-lacing here, and you maximized your PRF, you brought your baseline up, and the velocity is still going over into out of the screen, then move over to CW. So if go from PW to CW, this is the same velocity, same position. This is just a different scale. Okay, so we're at 1.74 meters per second. We're at 1.74 meters per second here. The scaling's just different. All right, so this is so important when you're dealing with aortic outflow lesions, such as subaortic stenosis or obstructive cardiomyopathy in cats. In cats, it can be tedious to get this apical view. Just work at it. It's all about flattening out the probe. Again, CW or PW to CW, and have a probe that you can just push a button and it goes right to CW as well. The last thing that I do, and this is an out-of-the-box Lindquist thing, and the reason I do this is because a lot of times the tricuspid valve, when I'm checking for right-sided heart failure or pulmonary hypertension and so forth, I'd like to have an idea of how important it is for me to find that minuscule tricuspid insufficiency that can be so difficult to find in some dogs. And so I'm going around doing my S-step protocol, and I get that tricuspid valve. Tricuspid valve looks good, it's closing well, strong, solid apposition. I'm not getting an insufficiency jet. But just to be sure, what I want to do is I want to take a look at the liver and the hepatic veins and the vena cava and the aorta. So you just slide the probe behind the diaphragm, and when I look for porous systemic shunts, this is an essential view in the abdomen where you should have a normal 1-to-1 vena cava to aortic ratio. All right, that's normal. That's been studied in the porous systemic shunt studies that we've done and others have done on ultrasound. You should have a 1-to-1 ratio, and you should barely see your hepatic veins. See your hepatic veins, primary hepatic veins, drop into the vena cava right in this area, okay? And this is a normal volume, and your portal veins and hepatic veins are typically 1-to-1. And this is a portal vein, this is a hepatic vein. So essentially 1-to-1 in width. Whereas when these become dilated like this, then you have a passive congestion pattern, and that's what happens when you have right-sided heart failure, pericardial effusions, or if you have normal right heart, you can have obstructive caval disease going on in the caudal mediastinum. Here's the diaphragm. This is the caudal mediastinum, and there, caudal mediastinum's back here, but you can see the vena cava through the diaphragm. You can use this as a window. So if we have a vena cava that's dilated and greater than a 1-to-1 ratio with the aorta, I know there's a passive congestion pattern. Now just go and scan the next dog you gave Domitor to, and it will mimic this phenomenon. But if the dog has not had Domitor, the cat hasn't had Domitor, and you have dilated hepatic veins that are wider than portal veins here, then you have to be concerned of passive congestion, which means you have to image the right heart adequately, looking for masses and pericardial effusions, but especially that tricuspid Doppler. Again, you have to make sure that you don't have insufficiency velocities over 3.5 or 4 meters per second or something like that that tells you that you have right-sided you have pulmonary hypertension or some sort of right-sided disease that would be responsible for this passive congestion pattern. Especially the next step would be to have ascites form owing to passive congestion. So this is the last thing that I put in the in the S-step echo protocol, even though we go south of the diaphragm. It's an important parameter to know, especially if you're doing both abdomens and chests, but it's a good little parameter to also monitor how well your therapy is working on right-sided heart failure. You know, if your medications are working, then this congestion pattern will start to go away. So it's a nice little thing to monitor. Now, no studies have been done that I know of. I would love to do this study and measure the normals, but I have to attack the other 6 piles on my desk before that happens. So now go back and do it all again. Realize that this takes practice. But once you get it down, it's actually much faster. We've been talking, you've been listening to me for about an hour now, and realize that I explained everything out, but this echocardiogram, when you have it down and you have the knobology down and you have the maneuvers down and you know that everything is just a slide of the probe, it's a tilt or a twist, then you will know that you can get in and out of echocardiograms with high-end views, all of these views, and diagnose all of the pathologies that we had up on our first page. You can diagnose all of these pathologies by means of the S-step echo progression, or at least have all of the views if you're sending out for telemedicine to be able to diagnose a pulmonic stenosis or an aortic insufficiency or an aortic stenosis or a tetralogy, or maybe you get to play with a bubble study. But it's all the same positions. So don't be intimidated. The pathology is going to be there. Just keep getting the positions that the S-step program shows you and adapt to your patient. And this is the last thing I'm going to leave you with you, is the best sonographers are the ones that adapt to their patient the best, okay? Because if you have a volume overloaded heart, for example, the position of the right parasternal 4-chamber long axis, or the brick, is not going to be in the same position of a dog or a cat that has normal volemia or is hypovolemic. So you have to be able to adapt, slide, find your sweet spot first before you start. And remember, do not start the progression until you have a long brick, a long right parasternal 4-chamber long axis. then get your measurements. That's the first thing. Everything goes right after that if you have a good brick. If you don't have a good brick, everything goes wrong. And it happens over and over and over again. So if you get that in your head, and I know I've repeated it 50 times now, just realize that that's where it all starts. It all starts with a good brick. So enjoy yourself, enjoy the curve, have a blast. If you have any questions whatsoever, you can always email us at info@sonopath.com. We're here for you 24/7. Hope you become a member. There's every pathology known to the probe in the abdomen, chest, dogs, cats, ferrets, birds. It's all there. There's hundreds of thousands of pages of information and case studies and things to learn from, as well as our interactive forum on sonopath.com. So we hope you take a look. It's priced inexpensively at $260 a year for a membership. I did that on purpose to make sure I wasn't going to price anybody out. From a vet student to a new grad to somebody who's been out a number of years, it should be affordable to everybody. And I guarantee you, once you utilize this site, you will learn faster than you will with any other modality. So thanks for listening. Have a great day.
So, doctors, we will have like around 5 minutes break. So we're going to have like 5 minutes break. So after 5 minutes, we come back to the second part. So for the second part, we're going to have to learn the protocol and the technique. So see you after 5 minutes.